everybody hear me? Okay, perfect. Thank you, Martine. I just want to get a heads up of, I know Schroeder, Martine, Susie. Hi, Faye. I saw, oh, Kristen. Hi, Kristen. Tracy. Where is just yell out where you're from in the world. Just so I get an idea. Anybody? Michelle, Cavita, Olive? Or type where you're from. Just a quick, Ireland, great, France. Perfect, okay, Vancouver. I just wanted to sort of get an idea of who's on the call. Tampa, yep, we're coming to visit you in Tampa. Great, okay, so it's kind of all over. So thank you very much today for joining my, my talk. I'm gonna put it on. And everybody can see that. If you can't, let me know or just shout out. Wainwright, oh wow, yep, Faye, you're in Wainwright. Perfect, okay. So thank you for joining this webinar today, and thank you for inviting me, Martine. I did finish schooling this year, and I decided to do my DN, my doctorate of nursing practice, only because I do really enjoy clinical practice and I wanted to stay in clinical practice. And where that takes me in the future, I'm not sure. But right now, I just graduated in October, and I am going to stay in my current job. And so for my schooling, I had to perform obviously the course content, and then a project, a QI project at the end with a thesis that I had to defend. And Martine was one of my amazing thesis advisors. So thank you, Martine. I'm not able to keep going though.
Do you see
okay.
Oh, yeah.
Got it, it worked. So this project was performed at the Princess Margaret Cancer Center, and I wanted to show a snowy picture of my son, only because this is our temperature in Toronto. My kids love the snow. I love the snow. For you in Tampa, I know I don't think you see much snow down there, but and it is snowing today. So I wanted to show you the weather here, and there's our Princess Margaret in Toronto. And I'm not going to, I know all of you are experts in older adults with cancer, and therefore I just wanted to show that new patients by age cohort at Princess Margaret. So I did not get the 2020 report. I suspect that there was a lot of issues with COVID, but so this is from 2019, and new patients by age cohort at Princess Margaret, 65 and older, over 40%. It's closer to the mid 40s. I suspect it's higher now. It's probably by 2021, it's probably later, like 46 to 48% of our new patients at Princess Margaret are 65 and older. And so background for this project, I wanted to look at patients, obviously in my clinic are all 65 years of age and older. So I work in the clinic called the Older Adults with Cancer Clinic, and we started it in June of 2015. And I joined a few months after, I joined in October of 2015. And so at Princess Margaret in our clinic, we have continuous follow-up for patients undergoing radiation surgery. So I'm not sure what it's like in clinics around where all of you are, but our patients that we see in our clinic are either undergoing surgery, radiation, or systemic therapy, or a combination of the above, including stem cell transplants, transfusions, immunotherapy, targeted therapy. And so for patients undergoing radiation, we will see them if frail, they're referred to our clinic, and we will see them prior to radiation, and they have continuous follow-up. So they go to radiation. We have a radiation nursing clinic that patients can drop in for any sort of issues or emergencies 5 days a week, as long as they're undergoing radiation, and even afterwards, for a couple of weeks afterwards, they're allowed to drop in. Our surgical patients that we see, they have surgery. So we assess them in our clinic and determine whether they're fit for surgery or not. They undergo surgery. And if they undergo surgery, they are obviously, they are hospitalized, they go to rehab. Our geriatric team will see them in clinic if need be, or in hospital if need be, and then they are sent home with the appropriate referrals. And in Canada, we have government funded nursing and some resources that will go to visit patients at home. And then currently right now, there's no standard follow-up process for our older adults undergoing systemic therapy after they're assessed in clinic. So we'll see them in clinic, determine if they're fit for treatment or not. And again, patients that come to our clinic are referred to us because the oncologists are concerned. And so they're undergoing systemic therapy and then they're sent home. So they have treatment and they go home. They're provided with a phone number for nurses, the clinic, the chemotherapy nurses and the clinic nurses, but there's not necessarily anybody following up with them. And as we know, in the last couple of years, more visits are telephone or virtual. And please jump in. And if anybody has any questions, please just jump in at any time. I'll try to watch the chat, but it's better if you just jump in and ask me a question. So the importance of the project, how it will impact future practice is we really wanted to understand the symptoms and severities for older adults undergoing systemic therapy. We wanted to determine the frequency and timing of our proactive phone calls because we did make in 2019 and 2019, we made 130 proactive phone calls, but that was over a large period of time that we looked back through the charts. And we just counted the phone calls. We didn't capture any data on it. We didn't know if it was actually helpful. Is it worth our time? Is it wasting our time? So we wanted to know if the proactive phone calls that we're doing decreased unplanned healthcare visits for our older adults. We also wanted to implement some sort of practice guides and evidence-based safer care. And this is one of the sort of first projects, including 65 years of age and older. There's several, and I'll talk about it in the literature review, of proactive phone calls, but this one is one of the first ones, including 65 plus for all types of cancer, including all types of systemic immuno-targeted therapies, stem cell transplants that I am aware of. And I did email Dawn Stacy, and I'll talk about that. And she also wasn't aware of any other major studies that did proactive phone calls looking at unplanned healthcare visits for patients, specifically 65 and older. So first of all, when I did a review of the literature, I looked at thousands of articles and I nailed it down to approximately 51 articles. And I looked at older adults with cancer. So the three themes: evidence-based interventions for patients undergoing systemic therapy, and then measuring outcomes. And so in looking at some of these articles, I just provided a few for each. In looking at chemotherapy, we know that older adults causes more treatment commonly causes more treatment toxicities due to increased comorbidities, decreased mobility, lack of social supports, cognitive issues, decreased nutrition, and then the list can go on and on. For hormone therapy and targeted and immunotherapies in these articles, they were associated with adverse events such as increased or decrease in blood sugars, thyroid issues, arthralgias, GI concerns, pain. And then looking at evidence-based interventions for patients undergoing systemic therapy, I will talk about the CoSTARS practice guides. For proactive telephone support and patient-initiated support, there was a study performed by Dr. Krzyzanowska, and I will talk about that a little bit later. But in the end, they performed proactive telephone support and found that it did help decrease emergency department visits. And then I looked at measuring outcomes. I looked at improving self-care behaviors. I didn't measure it. I just didn't have time. But in several articles, and one I included here by Lewis, it found that patients experienced at least one hospitalization while undergoing systemic therapy. This was specific to older adults. And what they found in this study was that older adults were found to benefit from a follow-up phone call after discharge. And then also I did measure decreased unplanned healthcare visits, and I will talk about that in a few minutes. I also included a mixed study systematic review and examined 10 qualitative and quantitative articles from 2010 to 2016. And what it found was that telephone follow-up by nurses improved patient outcomes, improved patient self-management, increased the lines of communication between patients, and helped reduce post-discharge complications. The only thing is that it wasn't specific to older adults. And so that's where the literature and the research is really lacking. And in my literature review, I actually included articles from 2016 to 2021. I tried to stick with the most recent articles. In examining the practice gaps, I looked at, I'll go through a few articles. One was a retrospective analysis, looking at specifically older leukemia patients, and they examined over 1,040 hospital admissions in 2 tertiary hospitals in the US. And what they found was that possibly 649 of them could have been avoidable. What they didn't really go into a lot of detail. They did go into some detail, but I would have appreciated a little bit more detail, exactly what were all of the avoidable issues, but they did mention pain, neuropathy, sleep issues, fatigue, things like that. In another article, at the Cleveland Clinic, they looked at over 1,000 unplanned 30-day readmission rates post-surgical. And in this study, nurses provided proactive phone calls upon discharge from hospital. And in the intervention group, it was interesting, it was 4.5% lower, so 439 patients. They used quite a large sample than before the intervention, which was 722. And in another study by Fowler, 751 older adults with leukemia. When they looked at it, they did a retrospective analysis and chart review. They found that 125 of these older adults with leukemia had an emergency, at least one emergency visit within the first year. In a pilot study, so this one was done actually at our center. Dr. Krzyzanowski is a medical oncologist at Princess Margaret. They performed this pilot study with in two areas at Princess Margaret and Sunnybrook. They looked at nurses making proactive phone calls within 24 to 72 hours after systemic therapy. And then 10 days later, Krzyzanowski focuses a lot on GI cancers. And then 10 days later for 73 patients to help manage symptoms, decrease emergency department visits. So in their comparative group, very interesting, they had 257 ED visits within the 24 to 72 hours and then 10 days later. And then in the intervention group, they had 50. So after nurses made proactive phone calls, it quite decreased significantly. And then hospitalizations in the comparative group, there were 59. And in the intervention group, there were 24. So I found this really interesting. When I talked to Dr. Krzyzanowski about this study, they didn't use, they used a different sort of, what do you call it? Practice sort of telephone practice guidelines. They didn't use the ones that we used, but still it's very, very interesting. What they found was a lot of the issues were nausea, vomiting, constipation, joint pain. And they used in this study, they used 6 nurses and 2 oncologists and 1 pharmacist. In a prospective randomized control trial for GI patients with a mean age of 50 taking oral capecitabine, they performed weekly phone calls for 82 patients. And what they found is that it increased patients' adherence, tolerability, less toxicities, and overall survival increased. They did not measure in this study unplanned healthcare visits or emergency visits, but I did include this in my analysis. I found it is very helpful. So in looking at, so those of you who are from Canada will understand the Edmonton System Assessment Scale. So when we call patients or we see patients in clinic, we are using this scale. It consists of 9 items, and we ask patients to either do this themselves, their family can do it, or we can do it. And we are also, we're using this as well over the phone. As you can see, it's helpful. What we're supposed to do is if they rate any of these issues 4 or higher, we are supposed to circle them and then assess them. That being said, we have novice to expert nurses in our clinic and in all of Princess Margaret. And so it's fantastic if you've been nursing for quite a while, but if you haven't, then what do you do with a number of 4 to 10, especially if you have no experience in any of these areas. And so there's no sort of guidelines afterwards to help us continue the assessment on these patients. And so what I wanted to do was implement the CoSTARS practice guides, or at least look at them when we're doing our proactive phone calls. And these were developed by Don Stacey and the University of Ottawa in Ontario, Canada. And they were developed over 10 years ago. They are endorsed by CANO, which is the Canadian Association of Nurses on Oncology. And they do recommend that all oncology nurses implement this or try to use it when doing follow-up care for patients. You can see it consists of 17 practice guidelines. And this is an example of the general assessment form. So when you call patients, CoSTARS Practice Guides stands for Canadian Oncology Symptom, Triage, and Remote Symptoms Practice Guides. And so when you call patients, they provide you, Don Stacey and Dr. Don Stacey and the University of Ottawa provide all of this information online for free. And what they provide is a general assessment form. And what they want you to do is when you call patients and assess these practice guides over the phone, they'd like you to use this general assessment form as a guide when writing down the information. And it just helps you with organizing your thoughts, organizing the assessment. And so what we wanted to do was just look at this and sort of see how we could implement this into our clinic when we made our proactive phone calls. And this is an example of one of them. As you know, that there's 17 now. And so with this, I actually used this one a few months ago, only because when looking back at these 17 practice guides, I've been a nurse for quite a while. I'm not an expert at assessing them remotely over the phone, and it can be a bit more challenging, as all of you know, to assess these over the phone with patients that may have cognition issues, may be hard of hearing, and then just trying to tease some of this information out. And so one of them that I'm not like extremely familiar with is bleeding. I can do it in clinic, but challenging to do sometimes over the phone. And so I found this helpful a couple of months ago when I assessed a patient. I called them and they said that they had started some bleeding. And so trying to tease out where the bleeding was, when it started. So I actually followed this. I didn't follow it exactly to the T, but I used a lot of these questions and I found it very helpful. And then it's also helpful when you need to go back and explain and talk to the most responsible for physician. It helps when you're emailing them or talking to them, and it provides them with a better understanding of what you've assessed and how severe the bleeding is for this patient, and then what the next interventions are. And so for the QI project, I used a couple of studies to guide it. One of them is by Dr. Davis at UC Davis, and they looked at a retrospective analysis. And the reason why I chose this is because this is one of the only studies done out there using the CoSTARS practice guides. So they did a retrospective analysis looking at 60 patients with a mean age of 59. Nurses performed 594 proactive phone calls bi-weekly to oncology patients who were undergoing systemic therapy. And they also did a chart audit. What they found was that there was a lot of patients that had nausea, vomiting, fatigue, peripheral neuropathy, pain, decreased appetite, depression, constipation, and anxiety. And so they found in this study that nurses were able to use the CoSTARS to help manage early symptoms for these patients, and also helped manage symptom severity. So it was a very, although it wasn't a large randomized control trial, it was very helpful for our project. And then two more projects that were done by Dr. Stacey et al. At the University of Ottawa, who actually developed the CoSTARS practice guides. One was a QI project performed over 60 days, and 113 audio recorded proactive phone calls were done by nurses, and they also looked at the chart audit. The mean age was 64 years. And what the results demonstrated was that there was higher symptom management for patients when the nurses used the CoStar's practice guides. And the other thing was that nurses were able to work to their full scope of practice. So I found that very helpful. Just because they were able to work to their full scope of practice, then they were able to manage some of the symptoms over the phone remotely without the use of a medical doctor. Although they would have emailed or called or talked to the medical doctor in person about what they did, they didn't need as much advice from the medical doctor when they used the CoStar's practice guides. And then another quality improvement project by them in the University of Ottawa, examined emergency department visits. And I found this helpful. They found that on average, there was 225 emergency department visits every month. And this isn't, again, specifically older adults, but the mean age was in the 60s. And what they found was that 7 of them, so 9% of them were deemed appropriate for the emergency department, and 91% could have been managed remotely. Again, this is prospective and examining the medical charts, but they found that they could have been better managed possibly by using the CoStar's practice guides and nursing calling them. And then the other thing was they found in this project was that 31 patients that did go to the emerge didn't call any nurses before they went to the ED. They just went to the ED. So they also recommended that they need to work on opening up the lines of communication and making it better for older adults, or I should say adults mean age of 60s, open up the lines of communication between nurses and patients. And so the clinical question we wanted to look at in our clinic was to what degree does the implementation of the telephone support using CoStar's practice guides impact unplanned healthcare visits among older adult oncology patients in an ambulatory clinic over 4 weeks. And I had to do a short period of time. Otherwise, it would not have been deemed a quality improvement project as per our ethics board at Princess Margaret. And so what do we do to help alleviate the current issue or problem? So I talked about currently we use the Edmonton System Assessment Scale. It's great, although it doesn't provide, even myself who's been a nurse for many years, it doesn't provide me with any extra guidelines beyond what is on the one piece of paper to assess remotely over the phone. And so we wanted to implement the CoStar's practice guides in our clinic for older adults with cancer. We looked at a quantitative quasi-experimental sort of methodology, and 2 clinical nurses performed the follow-up calls in the intervention and comparative groups. And so we looked at last spring, 2 nurses made phone calls proactively, subjectively, randomly in the comparative group. And then for the intervention group, which was performed last summer. So we used 2 months, so March and April for the comparative group, and then the intervention group, we looked at May, June for our patients. We used the CoStar's practice guides and the general assessment form for the intervention group. And in our clinic, we included all patients undergoing systemic therapy. We did not exclude any unless they didn't pick up the phone. And the only reason is because this is our sort of standard of practice, is we'll call patients subjectively who we feel are frail or might require a phone call. And we call them on their first or second cycle. And then they have to speak English, or an interpreter was used, or a family member was used. If they had cognition issues, we did not exclude them. We used a power of attorney, which we always determine in clinic when we see them. And they had to have been a patient in our group. They had to be 65 and older, and no informed consent was required, as it was waived as per ethics, because this is already sort of a standard of practice in our clinic. Although, again, the proactive phone calls we make are subjectively. And so in our clinic, what we ended up using and sort of patient demographics is, in the comparative group, we called patients. And then in the intervention group, we used clinical nurse specialists, and they called patients proactively. So they had systemic therapy, and we would have called them within 7 to 14 days after they started their systemic therapy. And I'll talk about that in why in a little bit. So in our project, the mean age in the comparative group was 81, and we did have 26 in the comparative group, again because it's only over a 4-week period. The range was 67 to 93. Majority of them were female, just randomly how that happened. Because we do see a mixed population in our clinical site. Majority of them spoke English, and again, if 2 of them did not. Majority were GU cancers, and then hematological cancers and gynecological cancers. Again, it depends on month to month in our clinic. It's very random as to the referrals we receive. 14 of them were undergoing chemotherapy. 6 were immunotherapy. We didn't have any targeted therapy. And there was 4 undergoing hormone therapy. None of them in the comparative group in that month were undergoing radiation at the same time, which is surprising. We do get a handful. And other is stem cell transplants, blood transfusions, immunoglobulin transfusions. And in the intervention group is where we made the proactive phone calls within 7 to 14 days after systemic therapy. The mean age was 81. Again, majority were female, English speaking. Actually, 5 of them were, we had to use an interpreter or family. The majority of them were GI cancers in this one, followed by hematological, and chemotherapy was the majority, followed by a couple of immunotherapies and some hormone therapies. We did have a couple undergoing radiation at the same time. As well, we had a couple undergoing stem cell and blood transfusions. And so when we did the data collection for the comparative group, we looked back, we did retrospective chart review and looked back through the electronic patient record to collect the data on patients within a 4-week period. And we looked at the number of phone calls we made, what we did, and we collected the information on the CoSTARS general assessment form in order to make sure that we were collecting the exact same information in the intervention group and the comparative group. And then in the intervention group, we used the CoSTARS general assessment form, and we collected data for 30 days during the intervention. And what we did was, when we made the proactive phone calls in the intervention group, we made the proactive phone calls within 7 to 14 days after treatment, because we didn't want to necessarily collect information about, so after, we know that the data shows that after patients receive systemic therapy, some of the major concerns within 1 to 3 days are febrile neutropenia, nausea, vomiting, some of those major side effects that they will receive post-systemic therapy, and therefore a lot of those patients will end up going to emerge. And so therefore we didn't really want to necessarily collect that data in our clinic. We wanted to collect more of the general overall data, especially older adult geriatric information. And so therefore we called patients within 7 to 10 days or 7 to 14 days after their first or second systemic therapy. And so in the comparative group, when we looked back, we found in the 26 patients, we made 8 proactive phone calls. 9 patients called us in the comparative group in that 4-week period. Number of patients that we resolved the symptoms not using the CoSTARS practice guides, we would just use the general ESAS practice guides. 9 of them were resolved. We had to refer to the medical doctor in 9 of them. And there were 11 unplanned healthcare visits. And some of them, when we look back, could possibly have been avoided, only because when we look at them, there was constipation, there was diarrhea, pain, some peripheral neuropathy. And so some of those we could have assessed definitely over the phone. A lot of the patients, so I listened recently to a talk by our geriatric pharmacist, who's fantastic at Princess Margaret. And she said, for general geriatric patients, some of the numbers of phone calls and emerged visits for older adults relate to, in our area, relate to diabetes. So they're not taking their diabetes medications correctly. Constipation, a lot of them end up going to emerge for constipation. And the third one was bleeding. And I did not know that, but it was very interesting. So, and then in the intervention group, we made 32 proactive phone calls. So some of these, there was a couple of them that we had to call patients twice, but regardless, there was a couple we called 3 times, but 32 proactive phone calls by 2 clinical nurse specialists. The number of patient initiated, so patients, of all of those 20 patients, one patient called us for help. 11 patients, we were able to resolve the symptoms by ourselves using the co-stars practice guides. Number of patients that we actually had to get help from the medical doctor were 7. And there was a decrease in unplanned healthcare visits, and it was 5 of them. And in looking back, and we had a expert statistician go through the results, as well as one of our medical doctors in our clinic who was blinded and didn't know any of the patients or the medical record numbers, went through the data to ensure that all of this was correct. And the 5 we could not have actually stopped at all. So one of them, several of the issues were severe bowel obstruction, and unfortunately that was a gynecological patient, and bowel obstructions are quite common, although they do have a protocol. It was unavoidable. One patient died of a heart attack at home. One ended up having febrile neutropenia. One of them fell and hit their head severely. So when looking back, we actually couldn't have avoided any of the 5 unplanned healthcare visits. And so what I just wanted to show and highlight is that because it was a smaller sample size, the p-value was not significant. But for a small quality improvement project in our clinic, I found that this was definitely clinically significant. So for this, recommendations would be obviously for a longer period of time. But again, because this was a quality improvement project, we were only allowed to do it for a certain period of time without receiving any informed consent as per our ethics. I would love to do a larger sample size, maybe even just starting with a retrospective analysis, going through the charts to see how we're doing now and compare it to a year ago or 2 years ago. The other thing I didn't include was patient comorbidities, which I wasn't allowed because it's a quality improvement project, but things such as diabetes, we see a lot of diabetes, we see a lot of heart conditions, a lot of osteoarthritis, osteoporosis. So things like that, I was not able to collect, and how that would have necessarily affected our patient care, as we know that one of our patients did end up having a heart attack and dying at home. I would love to do this not during a pandemic, and obviously a larger study, as I talked about. So some of the takeaway messages is that, and I think this is important to think about globally, is that whether it's the co-stars practice guides or not, some sort of practice guides are beneficial for nurses and staff to help with symptom support and manage remotely, as I'm sure worldwide our practice has changed in the last couple of years. Ours certainly has changed in the last 2 years, and we're still seeing a lot of patients in person, but we are also seeing, we're doing a lot of our follow-up calls remotely, and we used to bring patients in person, but now it's pretty much remote. So it's getting a little bit more challenging, and so therefore having some sort of practice guides, whatever that may be, I found is very beneficial. We are going to continue to perform proactive phone calls, and we have within 7 to 14 days to hopefully help decrease unplanned healthcare visits, just help manage symptoms remotely, increase patient safety, and hopefully saving costs to our healthcare system. Hopefully educate and empower patients to recognize and manage their symptoms at home independently. Although I didn't measure this, it definitely, we were able to talk to patients. They were much more appreciative of our help. They really did not want to go to the emergency department, so they really spent a lot of time talking to us and called us if they needed to. And then for our older adults with cancer, it helps open up the lines of communications between patients and staff and family members. So what we found is it's very beneficial for older adults with undergoing systemic therapy. And I just want to say a special thank you to Dr. Putz and Susie. Thank you, my partner in crime at work, who is the other clinical nurse specialist at Princess Margaret. And I know it was fast and quick, and I hopefully don't want to take up all of your time, but I open up to the floor if anybody has any questions.
Thank you, Raina, for that excellent presentation. And indeed, I was going to ask who has questions for Raina.
Hopefully none.
Can I just ask a quick question, just in relation to the presentation was great, by the way. So if you're continuing these proactive calls, just around the frequency, you said that you kind of called patients either the first or second cycle, or if they're continuing on treatment and you're continuing to follow those up, are you just kind of triaging what the patient's risks are and basing it on that, or is there any set number of cycles, or how do you highlight those patients?
Yeah, great question. We're actually meeting next week in as a team to discuss it a bit further, but right now, because we're so strapped with just 2 of us, we are only calling them after the first visit, like after the first dose of systemic therapy within 7 to 14 days. But if we feel, which Susie and I are sort of doing subjectively, if we feel that they're frail and not doing well, we'll continue to give them a phone call. Like as an example, I called a patient yesterday, who I was concerned about, and then so I emailed, and then the doctor actually ended up calling the patient today and verified that he was concerned. So therefore, I'm going to have to call the patient back again next week. So it's sort of right now it's after the first visit, and if there's no issues, we're leaving it with our phone number. And but if we feel like they're isolated, frail, or have cognition issues, or if there's any other major issues, we'll give them, we'll call them again after their next cycle or when need be. But we're really trying not to phone too much, as we're strapped for staff. Does that make sense?
It does. Thanks for that. Yeah, I think yes, the feasibility of the staff, and I think it's an issue probably everywhere, isn't it?
Yeah. Great question.
Thank you. Tracy has a question, has her hands up.
Yeah, thanks for this. It's actually, this is my research area of focus area of research. My dissertation was a proactive nurse delivered telephone intervention, but what was different was that I did education session first, and it was a pilot study, and I had 50% older adults, 50% over 65, 50% under 65, and I published my research in Oncology Nursing Forum in March of this year. And now I'm doing a larger study, which is actually mixed methods RCT with 98 patients. And what I did was, but what I found in the pilot was the older adults, well, there's literature out there, and I'm sure you found this, that they like to talk to, there was a distinguished difference between automated systems and nurse delivered interventions, for sure. And older adults like to talk to people versus machines. And I just found, while you were talking, I found interesting data from the IMPACT trial that said that patients with high symptom severity didn't even like to push the prompt to then get to the nurse when they were having symptoms. So that's really interesting. And that just kind of lends credence to the importance of having nurses help patients manage symptoms, because what we do is we educate them and then we throw them out there and say, okay, self-manage your symptoms. So again, more rationale for proactive symptom management versus reactive symptoms. And then also in my pilot, the older adults said, you know, the emotional support was just something that they couldn't put a price tag on. It was because I interviewed, it was mixed methods. So I interviewed patients and their caregivers after the intervention was over, and they just couldn't put a price tag on it. And so I'm measuring actually emotional support now in this mixed methods study.
No, you're not.
But I was wondering, did you take a look at, and this is something for future, did you take a look at who received education and who didn't receive education, or did you know that they all received education ahead of time, the same symptom management education?
That's a great question. Tracy, can you send me your study? Because you said you published it.
Oh yeah, I can send you the link. It's
Okay.
It's the pilot study. Yeah, but right now what I'm doing is I can send you the link to my clinicaltrials.gov, the study that I'm doing right now. We actually took the intervention and I culturally tailored it. And I'm trying really, I'm not limiting to older adults, but what I did is I'm actually studying it in Hispanics and Haitian Americans now. So we're doing it a little more. We took the suggestions of the pilot participants and we tweaked it, and we but you can see that. I'll send you the link to the article. I'll send the article, and then I'll send you the link to the clinicaltrials.gov for my study that's going on right now. But
yeah, I'd love to see it, just because I did my lit review before March, so I didn't see yours, but I'd love to see the one in March. So send it to me, but
yeah.
or send it to Martine or whoever, and I'd love to read it.
Yeah, I'm also thinking it would be great, Tracy, if you would be willing to present it and your current work, how you adopted it, because I think even though not everything was with older adults, I think it would be very useful for others on the call that are still maybe earlier in their PhD and things like that to learn from your findings and that we can all learn from it and hear about them.
Mhm.
Yeah,
Great.
and what also I found out in the pilot was, even though I only had 11 participants, I actually did a retrospective comparison group. And another thing that, along with the proactive, was that I really want to keep people out of the ED. So it was actually geared to preventing dehydration too. So anyway, if I speak early, I don't want to blow that, but my future presentation, but yeah, so there's a lot of things. I'm just saying that your research, your QI project, and then what I'm doing, and then it's just that it's great to have automated systems, but I'm telling you, just there's no replacement for nurses and in this role of proactive symptom management.
No. And that's, sorry, I'll answer your question. It's great. So all of our patients receive, before they start systemic therapy, they do receive education, how brief that is or not. So we do have oncology, we have courses for patients that they can attend, but how many patients want to come in to Princess Margaret and sit in a classroom anymore during COVID is not feasible. So they're getting a lot of the systemic therapy teaching in clinic, but while the medical oncologist sees them. And so it's really challenging right now. It's really rushed, but they do get it. And then they receive a phone number, like you said. And when they call, I have so many patients that say, I don't know what button to push. There's choose 1, choose button 2, choose 3 for a nurse. So I suspect that a lot of them aren't calling the chemotherapy nurses. And that's why we wanted to call our patients proactively, which we have been. And we know a lot of patients have challenges dialing the phone number, hearing over the phone. And I think our clinic is just a bit more obviously used to this. We're able to, we've met them before, they know who we are. I always call them and speak to them. When I know that they're hard of hearing, I will say, I am the nurse with the black hair, and they go, oh, I get it. So just helping to put a face to my name, and then I'll call them and say, this is what I'm calling to follow up on. We give them an instruction sheet when we see them with our names, our numbers. So you're right. I do think it's very important versus a machine. I did look at that briefly, but I didn't include a lot of that in my my lit review.
Yeah, there's just so much we can do. I mean, that's the one thing that I said in my paper was that, you know, it's just something that emotional support was just something that we just can't get from a machine. Because I had 3 people out of the actually 9 that completed. We had 11 that went halfway, and the 9 completed, that I actually said to the nurse, you know, you actually helped me from becoming depressed. Oh. So that was just, you know, I love the qualitative research piece that you can get, you know, by doing mixed methods. I mean, you can get that rich data from doing mixed methods that way.
Yep. That's fantastic. I'm excited to hear about this. I honestly, I chose this, and I'm not an expert in this area, but this was obviously a gap in our clinic. And so it was very beneficial and helpful for us to sort of figure out what to do. It's great. I look forward to your study.
Other questions for Wena? Are others implementing similar follow-up services? it's always a debate how long to do this. So we have that for study designs too, as you know, Rena, and we did the genetic assessment trial, and we're doing the final analysis, but it had no impact. But it's the same discussions we had there: how many phone calls to do, and how long you follow them over the phone, and things like that. So we would love to hear from others.
Susie, you did a lot of these phone calls. Did you find them cumbersome?
No, not at all. You know, I think if the patient was really well, then it was sort of a fast call, but again, they were really appreciative that someone had called them at all. And if they were unwell, I think it was important to catch, and things that we probably would have, you know, the people that we now, or that we previously were sort of thinking, oh, I should probably call this person and check in on them, but just doing it in sort of a more regulated way, I think was really helpful. And I found the co-stars great to sort of trigger my brain to what exactly am I assessing on the phone, and sort of a way to do it in a more systematic way. So I thought it was not really cumbersome at all. And I think patients really, really appreciated it. You know, what would happen otherwise is we get the phone call the week after they've been admitted, or we go to follow up with them too late. And then that becomes really challenging because the person has become much more complex to manage, you know, from our perspective, but also, of course, you know, they've gone through something detrimental to their health. So no, I think it's really fantastic. I would just add also that since doing this, Reina and I have both noticed that other clinics have started to use more proactive calls within Princess Margaret. So that's been really great to see. And in those cases, we kind of decide if we think they're covering all the bases or if there's anything we could add by calling them, but we don't want to overburden them with too many calls. But it's been kind of exciting to see other areas starting to use this as well.
Thanks, Susie.
Thanks. Are there any other questions for Reina? If not, then I really would like to thank you, Reina, for your excellent presentation. And we look forward to seeing the results published. And if anyone on the call is doing also projects and things like that and would like to be presenting on them, because I think it's great to learn from each other this way, please email me and we can schedule a webinar. And as a presenter, you can pick the time and date that works for you. But we would love to hear from everyone's work and learn from each other that way. So thank you and have a lovely day. And then I hope everyone, next week we have the SIOG Nursing Allied Health Forum. We'll send a reminder out about that as well. But that's more an open, informal meeting to discuss the different projects that we're doing and where everyone can come and join everyone and suggest things we should be doing or topics you would like to hear more about. So we hope you can join that one as well, but we will send out a reminder and then we look forward to seeing you there.
Thank you, Martine. Thanks, everyone.